Good afternoon. Change is the only thing that's constant in the world, particularly in medicine, right? When we thought we were so sure about all the amazing medical advances, a respiratory illness brought us down to the knees. When we thought that telehealth would be only restricted to specialties and medical centers, it became a norm during COVID for even primary care. Just when I thought that after 2 years of doing all the online lectures, that I would be able to match the energy and clarity of Dr. Gittleman in the first in-person conference, my allergies and the laryngitis hits in. So change, change, and change. So welcome. Thank you for your interest in and continued interest in learning about how the changing world and overall change in the lives of adolescents is disrupting their mental health and contributing to depression and anxiety. But I particularly appreciate your continued interest in how actually to also manage these things in the primary care settings. Obviously, there were very aspirational projects about screening for depression and screening for anxiety in the primary care setting with the hope that we could somehow identify very early on and prevent depression and anxiety, but only to find out that we were actually identifying a lot more well-developed, moderate to severe cases of depression and anxiety, and there was nowhere to go, no place to refer to, or there were very long wait times, and we all had to pivot as to how do we actually manage it in the primary care setting itself. It's great to see some of the familiar faces from our previous joint initiatives, like Project Echo, PH Tipsline, or some of the quality improvement projects that we have done together. So glad to see you all. Today, we're going to build up on things that probably you have heard us talk about before regarding depression and anxiety. Just few disclosures, none of them really very relevant to this talk, but I continue to participate in both National Telepsychiatry Committee and Committee on Quality Improvement at American Academy of Child and Adolescent Psychiatry. I'm the lead consultant for Missouri Child Psychiatry Access Project, which is a multi-state project funded by HRSA about really providing real-time, immediate assistance to our pediatric colleagues all across the state of Missouri and neighboring states whenever there is any presentation of behavioral health in the primary care setting. These are some of the objectives for us, but I would also like to pose a question to our audience here. What would be most helpful for all of you at the end of this 60-minute talk that you could take to your practice and implement? Any couple thoughts so that I could really focus on some of those contents as well.
So, one of it, I don't need to say that it's easy, but it's much easier when a family comes to me and they have a clue of what's going on, right? Where I struggle, and I think the family struggle with more, is the child that presents maybe with chronic abdominal pain or some other issue that's manifesting as sort of a somatic complaint. How do I help get the family, after we sort of do the workup and realize that maybe other than some constipation, there's nothing physically wrong with their GI system? How do I help move a family towards sort of accepting of that diagnosis, or that that's a potential possibility?
That's a great point. So when they come for more well child visit or a physical sick child visit, and you think that the real origin of this issue and actual diagnosis is related to mental health, probably depression or anxiety, how do we tackle that? Great question. Yes. Anything else that you'd like out of this as well?
Our virtual attendee, we have treatment options.
Got it. Wonderful. Well, great. Well, we are fortunate to have the local expert, Kath Williams, talk about some of the resources, but we'll talk about the treatment options that could be done directly in the primary care settings as well. All right. So it's always helpful to go to the basics of what's happening there. Adolescence is one of the very exciting and also the nerve-wracking stages for anybody's life, including parents. Now, this is also the fifth stage in the overall stages of psychosocial development, and it's also called identity versus role confusion. So this is the time when our adolescents are experimenting, they're exploring, they're building some sense of self-identity through values, experiences, beliefs, and overall relationships and social dynamics. Now, during this time, they have successes and they have failures and they learn from it. And our job is to really be a distant supporter and active supporter, intervener, depending on what's happening. If at all, they go through this, and majority of them go through this successfully, they develop this really strong sense of self-identity that sticks for life. However, if they're not allowed to explore due to psychosocial issues, bullying, bad breakups, home environments, stressors, then it could result in role confusion, which can then present as really poor self-esteem, thinking about where do I fit in here? What is my role here? What am I doing here? They could also present as the drifters from job to job, decision to decision, relationship to relationship, and eventually develop really poor self-esteem, resulting in a lot more incidents of anxiety and depression. There's also this sense of existential crisis that occurs around 17-ish, when they know that in about a year they're going to leave the house and going to be an adult, but don't really know how to manage that real world. And it's also sometimes frustrating for parents of teenagers who are just confused with what could be seen as a pure defiance and complete disrespect, where their youth is excited about being an adult, but at the same time acts very immaturely and irresponsibly, and there is always that conflict that coming in. Now, it really reminds me of something that I was doing yesterday. My 5-year-old is learning how to ride a bike, and we just got the training wheels off. And so there is this excitement of riding that bike independently, but at the same time, he was looking back all the time to make sure that I was running with him. And at some point I had to let go, and still he would look back. And we just had to be ready to support him if he falls, and he will fall. And so that is that phase of really transitioning out of that family coverage, a lot of parental support, to being out there in the world by themselves. And so a lot of times it's very helpful as we're chatting with our parents that this is a role of almost teaching them how to ride a bike. And yes, you are there. You don't figure out to intervene every step of the way. Otherwise, you'll make them very dependent and they will not be able to manage anything independently. And so that explanation sometimes in itself resolves a little bit of anxiety and fear in the minds of parents. However, okay, all right. And so it's important that when we are monitoring our adolescents, that we keep in our mind that most of the adult mental health disorders actually start by age 14. We can really track it down with subtle change in their behaviors, with subtle changes in their academic functioning, with subtle changes in their social functioning as well, where they have started to show the signs and symptoms. And if we can intervene early on, which is why it's important to really monitor very carefully, if we can intervene early on, then there is a potential to completely change their trajectory so that they do not end up with severe mental illness and functional limitations and disability. Other than that, there's all the social stressors. And if you probably are seeing in your practices as well, a lot of trends about TikTok and TikTok-based diagnosis and TikTok-based idealization and TikTok-based presentations that coming to you, to your clinic, and telling them that they are probably experiencing this particular disorder versus that particular disorder. And ultimately, the source of that is a lot of social media and what is now socially desirable thing to do as well. Now, for those who have difficulty fitting in, and those really tend to be a little bit more socially isolated over time, which could be a sign for emerging anxiety and depression, it becomes a major issue as well. We also know that anytime there are major transitions in the development, it's very stressful. And that's why a lot of times we see sudden decompensation and severe mental health symptoms when there is change from high school to college, because all the workload, in addition to all the life changes and being independent in the dorm and overall academic expectations without the support and guidance, that really puts a lot of stress. But at the same time, the similar kind of shifts also occur when naturally kids are going from primary school to middle school and middle school to high school. So it really looks like a little stepped increase followed by a sudden jump. And adolescence is that phase as well when they're transitioning from middle school to high school, and that puts a lot of stress. So anytime there is significant concern related to academic decline and social isolation or irritability because of that, that may again be a sign of emerging depression and anxiety. There's a lot of issue with bullying, and there's obviously a lot of issues that we have seen over time that can not only lead to depression and anxiety, but there has been a significant uptick of eating disorders. There's been a significant uptick of maladaptive coping like cutting and self-injury, which may not be visible, obviously, and because they try to deflect that significant emotional pain into physical pain, thinking that somehow it's going to help them cope with it. And so being vigilant about any physical signs as you are seeing them during your well-child visit and the annual physicals, where they are really inappropriately dressed for the weather. It's a summer, it's 80 degrees, and they're coming in with full sleeves. And things like that, we probably need to be very vigilant, particularly in adolescence. And obviously, there's a lot of experimentation that can also lead to high-risk behaviors, experimentation with vaping and smoking and trying out drugs. And there's a lot of emergence of sexuality and promiscuous behaviors as well. But all of that, if still within the norm, is part of the adolescent experimentation. But if it really presents as a problem, then probably it is setting to be a full-form disorder. I think you all would agree that the last 2 years of COVID really turned upside down the adolescent's emotional world, as well as the physical and social world as well. Now, there has been significant social isolation. A lot of sense of support that they had from their peers or from school resources, etc., was gone. That ultimately probably resulted in a lot of rumination, a lot of repetitive thinking, a lot of self-reflection that was wrong and often influenced by all of these social media things, and that led to significant increase in depression and anxiety. Secondly, there was a lot of death and loss and a lot of grief that they were not able to grieve appropriately with the social supports, and that pent-up grief, that unresolved grief, has also been significantly impacting their mental health. We were very optimistic suddenly a year into the pandemic because certain advocates mentioned that there has been a 50% drop in the calls to DFS and CPS about abuse. Well, the truth of the matter was now the abusers were always there in the vicinity. There was no break. Kids are not going to school. They're not going to activities. They're always forced to stay together with a potential abusive parent or potential abuser who was not a parent, but is part of the family or living there. And that has led to significant outbursts of a lot of these cases that are coming up now that then initially presented to emergency room visits because of severe anxiety, panic, depression, or suicide attempts. We saw an interesting trend of what we call as car therapy, where a lot of adolescents, when they were connecting with their mental health professionals online through video and for telehealth appointments, they would actually go to the car and sit there and connect and talk because there was no other place for them to talk confidentially. And we really had to adapt a lot to talk about several sensitive things, including mental questionnaires, asking the questions about suicidality, safety and safety planning, etc. So point of that being, we really have to be proactive and vigilant about it, because in the last 2 years, that has really increased in incidence as well as severity as well. And overall, there has been a little bit higher access to lethal means, where everybody's at home, and the adults who may be using guns, adults who may have the pain medications, adults who may have other things within the house. Now, kids being there all the time had more access, and that led to a lot more suicide attempts as well as completed suicide as well. Again, a good reminder for projects like Science of Suicide or Storage Safe by AAP, and why those are very, very important and proactive. Now, as we look at depression in adolescents, it's a little bit different than adults because it doesn't necessarily always present with profound sadness. It really presents with a lot more irritability. Now, unfortunately, a lot of the mental health disorders are also emerging at the same time in adolescence, and they're not well formed. And that's why they might present as a vague complaint, and we really have to just explore it a little bit further. So to diagnose depression, again, this is probably what you already all know, a typical med school mnemonic of SIGI CAPS. You got to think about the sleep changes. You got to think about overall loss of interest, anhedonia, some sense of change in guilt, energy levels, sleep difficulties, and specifically talking about suicidal ideations and suicidal thoughts. Now, it's a myth that often parents would bring up, that I don't want you to talk to our kids about suicide because it might give them some ideas, and that's absolutely unfounded. In fact, asking about it very openly, obviously personally, just individually to the child and adolescent first, and then talking about it to parents truly saves lives. Now, for a formal diagnosis of major depressive disorder, you need to have 5 of those symptoms, at least for about 6 months or so. And you definitely need a key symptom of either irritability or low mood. And in adolescents, it is mostly irritability. But at the same time, we also need to think about the differential diagnosis, not because something else might mimic depression, but because depression goes hand in hand with many different things, starting with chronic medical illnesses, for example. Now, those are not exclusive of each other. In fact, if there is a chronic medical illness like diabetes and asthma or sickle cell disease, the co-occurrence of depression is up by about 75%. And when that happens and depression is not well treated and managed, the outcomes of those medical illnesses are not optimal. And the healthcare utilization is up by about 50%. So it costs the system, it costs the family, but most importantly, it costs the patient. And that's why we really meant to make sure that it is always in the differential diagnosis. But when you're seeing somebody with chronic medical illness, always think about potential depression, anxiety as well. But there are also some medical underlying etiologies that may mimic depression, like hypothyroidism, some deficiencies. TBI is another good example. Some medications that they may be taking, like oral contraceptives, can cause depression-like symptoms. Steroids, when they're taken chronically can cause depressive symptoms, or even antidepressants, when they're taken in about 30% of the times, they do cause some emotional numbing and a flat affect that may look like even worsening of depression, and we might end up increasing the dose unnecessarily. So thinking about what are potential causes that may look like depression is also very, very important in adolescence. When it comes to anxiety disorders, it's not a homogeneous one, as we all know. There are different types of anxiety disorders. When it comes to adolescents, though, there are two main. One is generalized anxiety, and other is social anxiety. Now, while separation anxiety is more of a phenomenon we see in younger kids, there are subset of adolescents where they might also have significant separation anxiety as well. So things to look for there are some of the keywords, the buzzwords, like keyed up, like anxious, being, or when you push them to the social group, when you push them for going to the game practice, or encourage them to go out with friends, they become super irritable, they push back and they have an outburst. That might be a potential symptom of social anxiety. In addition to that, if they have significant distractibility, a lot of fatigue, a lot of irritability, being tense, they get keyed up, they may not talk about this being anxiety, but they might present to you with headaches. They might present to you with functional abdominal pain syndrome. They might present to you with sleep-related difficulties, particularly difficulty falling asleep or difficulty staying asleep. When those things happen, we definitely want to consider those as red flags for anxiety as well. When it comes to differential diagnosis for anxiety, again, it can present like many other disorders. And as I said, distractibility and nervousness and restlessness is one of them. Well, we see that with ADHD as well. We need to also rule out bipolar disorder, but then bipolar disorder is fairly rare in that age group. So having any family history, the first degree relative who has bipolar disorder is very useful there. Depression, again, from insomnia to somatic complaints, goes hand in hand with both depression and anxiety. Any learning disorders, only if it's happening in the school setting or in the context of academics, we probably want to think about potential for any learning difficulties and have them screened for that. Sometimes autism, particularly the ones formerly called as Asperger's disorder, can present with a lot of rumination, a lot of social anxiety, a lot of difficulty with repetitive and ruminating thoughts, and that could be a potential consideration. Although now with more screening and more early age interventions, that's becoming less of an issue of having late diagnosis. But nonetheless, sometimes we see kids who are presenting at age 12 to 14 with classic symptoms who were never diagnosed with autism, but they're presenting mostly with anxiety. Similarly, from medical perspective, we should think about migraines, epilepsy, particularly like benign Rolandic epilepsy that starts around 12, 13, could present with sudden screaming, waking up, screaming, crying, becoming very anxious and going back to sleep, but not really a lot of daytime symptoms. And they could be misconstrued as nightmares and difficulty and anxiety, etc. Asthma, again, can present during the attack as anxiety, but there is an anxiety-provoking symptoms there as well. And so we really need to consider that as potential differential. Lead intoxication, again, but that's in younger kids, but something to always consider as well. And from endocrine perspective, hyperthyroidism is one of the more common ones that we often see on our basic workup when we are working for anxiety as well. Again, not to say that these are the differential and they are presenting as anxiety, but they can exacerbate anxiety or they could be co-occurring with anxiety as well. Some of the things that we have noticed, excuse me, as a lot of times is the cold remedies and things like trazodone as a medicine or Benadryl as a medicine at night, that can often have a paradoxical reaction, way more common that we think, that can present as anxiety as well. When it comes to screening for depression, this is probably now bread and butter for everyone, but PHQ-9, and following just the GLAD-PC recommendations and following the cutoffs for PHQ-9 for stratifying the depression as mild, moderate to severe. Promise measures are other ones that are often used in research settings, but have been used now in clinical settings as well, that have an added advantage of having measures of well-being and not just depression. But always clinical interview is very helpful. When it comes to screening tools for anxiety, again, there are broadband one and there are shortband ones. The two most common ones that we use are SCARED and GAD-7. Now, SCARED is more preferred. However, these are long. They're really long questionnaires. The benefit of that, though, when you do SCARED, you have an option of doing SCARED form also for parent. So you get the two reports and you can see what is the alignment of those symptoms and why, and if why not. And that could lead to a better conversation. We really think about screening tools as really important because that provides a semi-objective measure, because subjectively they might say that they're not doing well, but their scores are improving, and you can show them and encourage them. And on the other hand, they might be minimizing their symptoms, but their scores are actually really high, and then you can gently confront them and bring them along to what is the ideal treatment plan. When it comes to assessments, in addition to the screening, what we really want to focus on, that is a real determinant for what modality of treatment we're going to use, is the functional impairment. If they are anxious, and parents say they are anxious, and they say they are anxious, but they're actually doing okay. They are able to go to their typical events, that they are able to participate well. Their academics are okay. They get really stressed before exams, but their academic scores are really good. In those cases, probably we would be conservative and take a more of a skills route than the pills route, rather than vice versa. And so functional impairment should always be our marker for determining what treatment we want to go for. When it comes to treatment, first of all, what we want to do is validate and normalize, because about probably 50% plus of your ambulatory patient population is presenting with some or other mental health concern, and conveying that to them is really validating. And we can utilize some of these scripted sentences or use the common factors analogies to explain to both adolescents and parents that it's okay to have these symptoms, to encourage them and congratulate them for disclosing them, and take that partnership approach when it comes to a shared collaborative decision making. When it comes to treatment for overall depression and anxiety, obviously takes a village. It starts with psychoeducation, really providing a good rational advice, both for parent as well as child, about the psychiatric nature, the mental health nature of their presentation, even if they came for well child or just the physical complaint, is key. Then there are psychotherapy or the skills approach. Now, depending on where you are, you may or may not have access to it. But then fortunately with technology, we now have digital apps that could be a good bridge while they are visiting with their therapy appointments. And so there are different types of therapy that you can refer them to. First is more around cognitive behavioral therapy. The key for cognitive behavioral therapy is to ask the adolescent if their therapist is giving them some homework. And if the homework is being given, then we can say that, yes, they're actually telling them to do certain kind of exercises to change their cognition. Other one is just the behavioral aspects of behavioral activation, particularly when it comes to depression. And this behavioral activation is a good thing. It's not the side effect of medication, but something we say that you need to get up and get going, be on the schedule, eat three meals a day, get some exercise, be active, and sometimes using the terms like inertia, and once you start going, you will keep going, etc., are very helpful. Then interpersonal therapy is also very key, particularly when it comes to the self-doubt, self-esteem, social struggles, and difficulty with where do I fit in with the peers, etc. The school interventions are always helpful as well. They could have 504 or IEP programs that can help them, particularly in anxious children, to provide them with extra time for their testing, etc. And then pharmacotherapy is always there. But as we would suggest, we always want to take a skills first and pills later type of approach, because there's no skill in a pill, and only pills are not going to solve the problem long term. Quick overview of pharmacotherapy. These are some of the common medication classes. Not all of these are FDA approved, but just for your information, because oftentimes you might find yourself in a position where they came in with the list of medications and you are now expected to somehow provide refills, even though you did not start it, because they had established diagnosis, they were hospitalized somewhere, or they moved from outside town to your town, and you being the de facto mental health provider, unfortunately, are in a position of doing that. So for your information, these are the main classes and the names as well as brand names for that. When it comes to the overall approach of medication, again, you're very familiar with it from GLAD-PC perspective. For mild depression based on PHQ-9, we generally do not suggest medication. For moderate to severe, we do, depending on the functional impairment. So moderate depression, but not major functional impairment, therapy is the first step to go. But moderate depression based on PHQ-9 with significant functional impairment, you probably don't want to wait to start the medication. Severe depression, again, medication treatment is the way to go, with or without therapy. And eventually, both medication and therapy are very helpful. It's always a good idea to start with first-line SSRI. The two FDA-approved ones are fluoxetine and Lexapro. Now, there are some age differences as well. We generally do more than 50% of off-label prescribing in child psychiatry. And so you should feel comfortable in sometimes using the family history, the history of response by their first-degree relative for a medication for a similar presentation as one of your guides for medication selection. If the first lines SSRIs don't work, then you can obviously go to the alternative SSRIs only. Now, you might notice here that, for example, Zoloft is not listed, citalopram is not listed. But do we often prescribe it? Yes. And so you should not feel that you cannot prescribe it because it's not FDA approved. Then there are third line classes that could be used either as monotherapy or could be utilized as adjunct medications with them as well. A similar approach for anxiety as well, where again, we don't have GLAD-PC-like guidance clearly, but the approach is very similar, that if it's a moderate to severe anxiety and using functional impairment as your guide, you can go with SSRI first, and the next is SNRIs for the treatment. Now, switching medications is often a common question that parents ask us or we deal with as well. So when do we want to switch the medication? There has to be an adequate trial, both of dose and duration for a medication. So if there is no response or there's a worsening of symptoms, even with adequate dose after 6 to 8 weeks, probably it's time that you don't want to push the limit too much and then go ahead and switch. But how do we do that? Now, there are different approaches for that. One is to first wean off the medication completely before you start the other one. Oftentimes, that leads to further worsening and then a gap of 2 to 3 weeks where everybody's struggling. The parents are struggling, the child is struggling, and often that causes a significant disruption or sometimes visit to emergency room or hospitalization because severe decompensation. So unless it's necessary, we generally suggest a cross taper. So the ideal way of doing it is going down by 50% every 3 to 4 days. And after the first dose is down by about full 50% of dose, start the other one at the low dose so that you kind of do the cross taper. And at some point, then the first medication is completely weaned off. The second medication by that time is about 50% of the desired dose, and then you can titrate it further. The only exception sometimes is fluoxetine. The reason for that is fluoxetine has a little bit longer half-life. And so if when we are trying to wean it off, or we're trying to cross taper, there might be higher chances of side effects because of excessive serotonin in those cases. Brief principles when it comes to treatment of SSRIs, which are probably bread and butter by this time for you all. There's no really head-to-head controlled trial about which SSRI is better than others. They are all very much similar. So don't feel compelled to start with only Lexapro first, even though Celexa might be a better choice because mom had the similar symptoms, or their brother or sister had a similar symptom and they did well. It's okay to go with that medication. Now, when they are medication naive, we probably want to do a closer follow-up, not necessarily because we are looking for sudden improvement in symptoms, but for first 4 weeks or so, no news is a good news, and 2 to 4 weeks, if we are watching for any side effects, that's the time it will occur, and so we can manage it accordingly. So first few visits, or I would say about 3 visits, are 2 weeks apart, followed by then a month and then quarterly follow-up for that medication. Now, when it comes to anxiety though, it's typical that we may need higher doses of SSRIs than what we would use for depression, and more severe the anxiety, higher the dose. So for adolescents, it's okay for you to push Zoloft to about 200 milligrams. Don't feel that more than 100 is going to be somehow risky, or there may be any side effects. Now, sometimes we probably want to avoid any concurrent alcohol, drug, or any concurrent medications as well. Now, one of the key things here, and then we see it all the time, is any over-the-counter medications that they take for sleep, for energy. A lot of adolescents who are working out and doing other things, if they're taking supplements, etc., it's always a good idea to take all of that history, check for any medication interactions to avoid any serotonin syndrome or any other side effects. But in general, we want to assure parents that we don't want to prematurely change the medications or discontinue the medication because we did not see the effect. We need to set that expectation that first 4 weeks, no news is good news. 4 to 8 weeks is when we're going to see the effect. 8 weeks mark is a good yardstick for us to know whether it's working or not working. And eventually 12 weeks is actually when we are fully aware of a full effect of the medication. A few pearls from SSRIs. Citalopram has a rare side effect of QT prolongation if it's given more than 40 milligrams. Again, there's no need to get EKG at the baseline, but something to be aware of, because anyway, 40 to 60 milligram or so is pushing a little bit higher for citalopram. Lexapro, again, it's a good stepbrother of Celexa, so it's a more purer molecule, but it has a similar side effect profile. But in general, Celexa and Lexapro both are fairly well tolerated. When it comes to fluoxetine, one thing to consider is that it's very activating. And so you probably do not want to give fluoxetine in the evening because it might interfere with their sleep. It's also one of the medications that has very long half-life. So stopping cold turkey, although is absolutely not advised, and we always want to encourage them to do it under the monitoring of their physician. Fluoxetine is something that probably could self-taper if they decide to just stop cold turkey, and you may not have to do any major intervention there. Again, you don't want to disclose that to our patients, but you could feel okay that there's not going to be major issue of withdrawal symptoms from SSRIs. Now, typically, if somebody will stop their SSRIs, you could see flu-like symptoms. You can suddenly see runny nose, coughing. They also explain electric shock-like sensations in their arms and their head. They come to you and saying, I'm feeling like my head is getting zapped. But again, they might have flu-like symptoms as presenting complaint. And if they were on SSRI, that's a good time to ask if they have suddenly stopped taking medications without telling anybody as well. So in general, all these medications, all three of these medications are fairly good. One of the pearl that you could use is if it's depression that's more melancholic type, that's low energy, they just are not able to pay attention, they want to sleep all the time. Fluoxetine may be a better medication because it's going to be a little bit activating. But when the child is very anxious, who is extremely restless and gets keyed up very quickly, maybe fluoxetine is not a better medication because it might further worsen it as well. And again, as I said, sleep is another key point in this medication selection as well. Moving on to some other medications. Fluoxamine or Luvox. In the past 20 years, I have started 2 patients on Luvox and maybe continued few that I can count on my fingers. It's a fair enough medication, excuse me, for adults who have OCD-like features. However, it's a messy drug because it interacts with pretty much everything. It's a potent CYP1/2 and 2C19 inhibitor, and it can affect a lot of different things. It's also very difficult to wean off. And so we would recommend to stay away from Luvox, but just for your awareness, in case you find yourself refilling the medication. Paxil is another medication that has been a favorite for a lot of folks who are trained in old days, that from sleep to depression, Paxil was the pill. However, the safety data for Paxil in adolescents is not that great. In fact, FDA had issued a warning, not a black box, but a warning about potential side effects, including increasing suicidal thoughts because of use of Paxil. So if at all you have a choice, try to stay away from Paxil as well. Zoloft or sertraline, not FDA approved, interestingly, but very commonly used and very effective medication. So if you were to go from one SSRI to other SSRI, you could safely go from Celexa or Lexapro to Zoloft and vice versa as your default medications. Talking about some SNRIs, Cymbalta is interestingly FDA approved. Not a very effective medication for anxiety. It only had 2 small, not very impressive trials, but because they had trials, FDA approved it for anxiety. It might be useful when there are some pain syndromes. And so any neuropathy or any other things that are happening, it may be a safer bet because it might affect the pain as well. However, again, it's not the first line medication. So please don't consider Cymbalta as first line just because somebody came with anxiety, because it's not that effective. Something to think about from Cymbalta is potential for increased blood pressure, and you may manage that by reducing or increasing the dose. One thing to also consider about Cymbalta that's not written here, excuse me, is a potential increase in liver enzymes. Again, we don't probably want to do it at baseline, but if at all you are doing some baseline lab for some other reason and you see increased liver enzymes, if they're on Cymbalta, that could be one of the reasons why their liver enzymes are elevated. The other one that's actually an effective medication is Effexor. Again, a second-line medication after SSRI. Effexor venlafaxine, again, has some issues with blood pressure. One of the interesting one with this medication is night sweats. So even though it's effective and after failed SSRI trial, venlafaxine is helpful, night sweats is something that might be a major problem when they present to you. As long as you provide them with the counseling of the medication that it's actually common and it's very benign, and if they can tolerate it, then it should be fine. But we don't really have to worry too much because night sweats is a very well-known side effect from venlafaxine. Talking of side effects, there are some common ones that are very much dose dependent, but also that are dependent on just the use of medications, and they usually go away when you use it for some time. Some side effects like sexual dysfunction don't go away. If at all, it is related to medication. In fact, what we see is the opposite, that the sexual dysfunction in older adolescents is actually a reflection of depression severity, and as it gets better, it resolves as well. Rare side effects, as we talked about QTC prolongation, again, no need to really do any baseline EKG. There could be induction of mania theoretically, because again, most of the times, the first presentation of bipolar disorder is actually severe depression, but there are some atypical symptoms of that depression, like excessive sleepiness rather than insomnia, what we call as latent paralysis, which is feeling like their arms and legs are very heavy and they find it very difficult to move. When some of those atypical symptoms are present, then they could be a reflection of potential bipolar disorder. But again, when something presents as depression, please treat it as depression unless there is significant first degree relatives history of bipolar disorder. Serotonin syndrome is another potential one. Again, it usually is a medical emergency. So if you think about it as a potential side effect from taking SSRI along with something else, then probably want to suddenly send it to the emergency room to take care of it. Again, fairly rare, but something that you should be aware of. Serotonin syndrome also could be induced with not just two SSRIs, but some other medications like some antibiotics, lithium, and medications like Reglan. So when you're combining these medications with SSRI, always keep at the back of your mind some potential for side effects, particularly serotonin syndrome. Now, just because they have side effects doesn't mean that we have to completely get rid of the medication. There are ways to manage these side effects. So common issues of GI issues, you probably could safely ask them to take it with food and it resolves. Sleep changes, depending on its activating medication or not, change the timing. Headaches, more often than not, is related to dehydration if they're not eating well, and encourage them to eat and be on the schedule, and that usually resolves that issue. Sexual dysfunction we talked about. Serotonin syndrome, again, we probably want to discontinue the medication and send them to the emergency room. For elevated blood pressure, ideally, if it's within the range, it's higher, but it's within the range, and we know that's probably because of medication, then there's nothing much to do other than just monitoring. And if there's major fluctuation, then you might want to change that medication. Now, we cannot leave without talking about the black box warning and suicidality from SSRI, right? It came around in 2004 based on a study that showed that at the beginning of that study, 8-week study, 2.8% of the kids endorsed some thoughts of suicide, again, not really suicidality or plan. And at the end of 8 weeks with SSRI trials, about 3.8% suggested that yes, they had suicidality. Now, as it was picked up, it was like, wow, there's sudden increase. They did not look at the percentage, they just looked at the percentage increase. And then that led to a panic reaction leading to creation of the black box warning. Unfortunately, it was really not very valid. There have been very, very many follow-up studies of the same cohort, and there was actually never a poor outcome. There was never a completed suicide or suicide attempt at all. It was just increase in thoughts of suicidality, which may or may not be associated with antidepressant. In fact, the study showed over 10 years that as the prescribing rates for SSRIs went down because of this, there were actually increase in suicide, almost tenfold increase in suicides between 2007 and 2010. So while it's appropriate to discuss this as a potential major issue with SSRI, it's really a non-issue. So we need to really reassure the parents who might be looking at the labels and really concerned about their safety. So in summary, pills and skills together work. Always utilize functional impairment as your yardstick for using medication. Feel very comfortable about using medications. Side effects are often resolved. Appropriate counseling of parents and adolescents to set the expectation as to when you could expect full resolution or expect improvements is key, so that we are not prematurely changing the medications. And FDA black box warning, while it's reasonable to discuss, should not be a reason to stay away from SSRI and psychotropic medications. So with that, I'll stop and open for any questions.
Is there can we do questions at the end for both of you?
Oh, sure.
Would that be okay?
Sure. I'll then hand it over to Kathy Williams.
I will get ready to pass it over to Kathy. Just a few updates before I pass it over. My name is Alex Miller, and I'm the program manager for the Preventative Health program with Ohio AAP. And we have been doing a webinar of the month every month for the past about 3 months, and we will continue on for 12 months with the support of the Ohio Department of Health. And so we also have 2 new resources with each webinar, one for physicians and one with families, as well as the family resource being in Spanish. And if you scan the QR code and go to our website, you will see a list of all the recordings of our webinars, as well as all of the resources that we have available as well. And you can register for the rest of our trainings on that website too. And if there are any questions, you can send me an email or let me know, and I will go ahead and pass it over to Kathy now.
Alex, is this webinar going to be posted on there?
Yes, and this webinar will also be posted online. And if you stand here, they can see what's in.
Hi, everyone. It's nice to see everyone. Thank you for inviting me. I'm Kathy Williams, and I'm the manager for behavioral health for integrated services in Athens, Hocking, Benton, and Washington counties. I'm also the Help Me Grow director and the Ohio CAN director for our catchment area. Today, I want to talk to you about resources, but I think it's important for you to know a little bit of a background. We didn't get a chance to talk before, and I'm glad you said it takes a village, because that's what I'm going to say. What we know is isolated, we cannot fix any of the things happening right now, right? So together in the community, we'll do it all together. So some of the resources are from Integrated that I'll share. When I'm done talking about resources, there'll be a lot of resources over by the bags for you to stuff in the bags, take with you. So I'll just quickly share what I have and then open it for questions, because I'm not sure if everybody's from Athens or if we're going to look at other counties. So integrated services for behavioral health is open in 15 counties. We provide psychiatric care for children and adults, counseling services, community behavioral health work, which is also known as therapeutic behavioral health support, Help Me Grow home visiting, let's see, all kinds of stuff. School-based for kids, we do Ohio Kinship Navigator, just all kinds of pieces to the puzzle. We have early childhood mental health consultants, infant mental health consultants, which is near and dear to me. I know I was introduced as a chemical dependency counselor, but my passion and love came from this field for 26 years of working with families. And my passion is about getting there and getting in the middle of the chaos and figuring it out. And that's where this is important, that we're all meeting together. Oftentimes families come right through our doors through referral systems, right? Often through their pediatrician. You see something, you refer over to us. It's an easy way to get them excited about services. If you're talking about them, you know that we can meet people where they are. It's good for us and it's good for you. One of the other large resources that we have is Ohio Rise, which is new. We were just awarded the grant for CME for 2 catchment areas. And that's important for you guys because one of the things that you'll find out is that as the CME, there'll be an entire team wrapped around family. So if a child has been hospitalized, they'll get an automatic referral out, and we'll wrap services in many counties. So 19 for us, but all over the state of Ohio will be an increase in looking at depression, anxiety for all children, adolescents of all ages 0 to 18. Our partners are Hopewell Health Center and Health Recovery Services in Athens. We partner with Hopewell Health Centers on early childhood mental health. Help Me Grow. They have a whole early childhood team that's in multiple counties. You'll have a map. I'm going to set the maps over on the counter so you'll see exactly where they are. So when you're referring, you know who the partners are in that county. They also provide psychiatric care, mental health counseling, substance use counseling, early childhood mental health, lots of parenting program. They have PCIT training. They have parent cafes, just a lot of great resources. Our other partners are health recovery services. They're typically substance use services, but they serve teens and adults. There's Bassett House, World Women's Recovery, and then they also have counseling and case management services. So I have a lot of different resources to talk about. Help Me Grow. We have early intervention also at Hopewell. I'm hoping you're all familiar with those. But I'd like to ask you if there's specific resources that you guys need for Athens or other counties. Are you looking for specifics? Or are you seeing specific things that you wonder about? Does those agencies take referrals for those? Who can I call? What can I do? Any of those? And so if I thought, is it okay if I talk about early childhood, or would you prefer more like adolescent and teens for referrals? You guys just gonna let me do whatever I want, right? It's Friday. I was at a conference all week too. Let's just stretch and embrace it's Friday. It's no longer raining. So let's just talk about one of the things that we often see when referrals come in is that parents are recognizing something just isn't quite right, right? Whether they're an infant, whether they're a child, or whether they're a teenager. So that's where the journey begins, right? If they haven't gotten through one of our mental health doors yet, then they're going to produce at the doctor's office, right? So that's where the journey begins. And as a team, we're going to have to work together to help support the family. What we know is that oftentimes people don't want to ask for mental health. Even though we've gone through years and years of stigma around mental health, what we know is people still look when they walk into the door of a mental health agency. They still look around, or they say, oh yeah, my kid goes to see that doctor, right? When they're talking about medications. So as a team, that's where a high rise comes in, and a lot of the philosophy around Athens County is that we really want to meet people where they are. We want to be present. If we need to meet them in the home, we're going to do that. In the community, we're going to do that. In the school, we're going to do that. Anything we can do to reduce any stigma around mental health, any services, health problems, developmental delays, any of those items. Does anybody have any questions?
For the Help Me Grow early intervention, I know that's usually for like developmental disabilities. So I guess what age would you be doing the behavioral health?
Okay, good question. So Help Me Grow comes in two pieces, and particularly in this county, but not all counties, it's separated by two agencies. So for us in Athens County, Help Me Grow home visiting is done by Integrated Services, and those are for prenatal mothers up to age 3, and then the expansion to age 5 just came out yesterday. And then early intervention is by our partners at Hopewell Health Center, and theirs is for 0 to 5, Katie? 3, Katie's back there, 0 to 3. And so early intervention, you're correct, is usually around a developmental disability or delay that is suspected. And then they're sent over, a referral sent over, and an assessment is done to see if they're ready for services. Thank you for saying that. And you're probably getting ready to say this, but go ahead, Katie.
So that if there's a behavioral concern, we could try to capture that and work with the professionals
the family and the providers, and as well as pediatrics. So the behavioral health can start from 0 to 3. If there's more than just a consult needed, then there's a referral.
Perfect. Thank you. And while you brought up Help Me Grow, I think it's also important to know, do you want to talk about the OT and PT that Hopewell offers as well since you're being helpful? Did you want to talk about the OT and PT that Hopewell offers?
Yes, so we actually have allied professions. So we are able to offer OT, PT, and speech in, I'm gonna mess this up, like 17 counties across
Mhm.
southeastern Ohio, and all the way up into Adams Brown, so all of these back folks. And so what we're able to do is they actually go to the home and be able to provide that through our services. We also have a couple that are able to do an office space in those locations as well, and that goes up until kindergarten. So that's not just bound by that 0 to 3, but that actually goes up until kindergarten.
Great, thank you.
So as far as the expansion, you said that was just in
I-
this county? Or is it-
So I just got the state rule yesterday. There's an expansion to 5. So I'm not exactly sure how it's going to roll out. They sent it out a new rule. And as you know, hopefully nobody from the state's on here. Sometimes they send out the rule and it takes a bit of time to catch up with what they want us to do.
So then for the particular counties that we serve, we just ask if they have the infant mental health counseling?
So,
Okay.
so the infant mental health credential and counseling is normally someone who specializes in infant mental health. So in the counties that Hopewell serves, those are 17.
We have nine clinics. It's confusing. We have 9 clinics and we cover 24 EI counties, 17 for the OTPP speech, 24 for consultant. I mean, we're kind of all over the place. If you just call, we'll figure it out with you.
Yep.
Okay, 'cause I didn't lose their Hamilton, Butler, Warren County, so it's like, how would I know if they had those particular?
Absolutely. So
Yeah.
if you wanted to, I can get you my information. We'll figure it out for you.
Okay, thank you.
And the infant mental health consultation and early childhood mental health consultation is a bit different from Help Me Grow, right? So they're embedded together at Hopewell, so they can provide that seamlessly. Other entities may not have the same thing. So if you were coming to me for infant mental health consultation, I couldn't give you the piece that she could, right? Because I'm a different agency. We don't do the whole umbrella. So it will depend on your agency, but you could definitely start with your board of DDs for that information. I also wanted to bring up home visiting. If many of you don't know a lot about home visiting, it's prenatal. So we're starting with those moms as early as possible. The moment they find out they're pregnant, we really want to start working with them. We're meeting in the homes where they are. If they don't want to meet in the homes, that's fine. We will meet them anywhere, doctor's appointments, you name it. It's really important to start early, building those relationships, talking about their health and their child's health, environmental factors, smoking, all the things that get us ready for pregnancy and then bring us to your door with those bouncing babies. We stay with them again until yesterday. It was to age 3. Looks like there's a change to age 5, but there's a great likelihood that our home visitors will be embedded inside these families for almost 6 years of a family's life, which is pretty impressionable. When you think about if you can entertain families into their home with curriculum, evidence-based curriculum, building strong relationships for 6 years, you've got a pretty good foundation, because in that time, they're always asking them at every single visit, when's the last time you saw your pediatrician? Are your vaccinations up to date? What was the iron levels? We're looking at development, we're screening, we're doing ASQs, post and depression screenings, all the screenings that are going to lead us to your door. They're also going to lead us over to early intervention, because if there's any suspected delays, we immediately make a referral. So I want to just talk about how important home visiting is, early intervention, getting those foundational years. In Athens, I know all of you are not here, but we also are lucky to have a high university provides family nurse navigators. They're inside of our OBGYNs here in Athens. So the minute they roll through the door, they've got a partner to talk about pregnancy, what that pregnancy looks like, feels like, and they're a great referral source for all. We also have family nurse partnerships. It is new, and I do not think it has launched yet in Athens, but it's coming. It's from Children's Hospital.
go ahead and we go through
Great.
them too. We'll kind of open it up to questions for both of you. Haley, are there questions on
There
the
are.
chat? If you want to start with those or one of those, we can alternate.
Okay,
Go
so
ahead.
I'm going to try to speak loudly so that it picks up in the mic for everyone virtually. The first question in chat was, can you comment on nightmares and bad dreams and anxiety? One of our attendees said they've seen this come up a lot with anxiety patients, including dreams related to friends and parents.
Yeah, great question. Nightmares as a symptom is not necessarily always associated with PTSD, although it's one of the core symptoms of PTSD. Nightmares is a very common expression of daytime anxiety, particularly if the child is internalizing more than externalizing. Nightmares can certainly present. Now, one thing associated with that is in those cases, you probably don't want to use the activating type of medications because they can also cause what we call as very vivid dreams. And so sometimes if there's a treatment for anxiety, we are starting to treat them with SSRI, and then they develop kind of nightmares, it's always a good idea to ask whether they're really nightmares or these are just the dreams that are very explicit, they're very vivid, but are not causing them to wake up full of sweat with their heart racing, etc. And then when that happens, it's likely related to medication as compared to the actual nightmare because of anxiety. It's also a good idea to potentially screen for any trauma because it's possible that we never screened for it, we never asked for it, and this could be an expression of underlying PTSD-like symptoms as well. But again, very common and one of those common non-specific symptoms of depression, anxiety, PTSD, or medication side effect as well.
Any questions in the room?
Thanks, Chris. I just wondered, as you talked about kind of a strategy to move from first line to second line, is there a role, because I have parents coming to me about gene site testing relative to antidepressants or anxiety medicine. Where does that fit in, if at all?
Great. That's a great question about gene site and many other companies that are there. There's the psychogenetic testings. The answer for that is there is some role for a subset of patients. They might have genetic polymorphism that affects their ability to appropriately metabolize the medication. And so the only cases when it has some justification for use is if there is no response after multiple medications, if there is acute side effect even with low doses of medications, or if they have really weird, unheard of side effects. Only those cases that we can justify using that testing. However, the caveat for that is, unlike the way it's marketed, or as a lot of times our parents understand it, these tests cannot predict medication response or resolution of symptoms. So these cannot be the guide of which medication will help you. At best, and I'm saying with a lot of modesty there, at best, if at all it's helpful, they may predict if there may be a potential side effect because of genetic issues for that medication. And that too, oftentimes, clinical correlation is indicated. Or probably I'm sounding like a radiologist, but oftentimes you need to see that, okay? Now, what we see oftentimes is when we see the report, there's a green column, there's a red column. Green column is the one which are the medications that, yes, you can prescribe to the child or adolescent. The red column is the one probably not. We need to interpret as green columns are the ones which probably do not have that enzymatic reactions. They don't have any CYP-related issues. And coincidentally, they're also the brand name newer medications just because they're the newer molecules. And red ones are the ones that are generic, old, but first line medications. So again, the answer is it is useful, but not for the reasons that we often think it is useful. More for side effect prediction in rare cases, never should be used as a medication selection tool.
Thank you. We have another question from our chat box. And this is regarding or thinking about the developmental approach for adaptive coping skills learned over time. Could either or both of you comment on the importance of formalized social emotional learning in both preschool and school settings?
So I'll take that. Sure.
A question from Dr. Andy Garner, if anyone was questioning.
Well, as we know, our social emotional learning for children starts very early. This is the part I love, right? When people say, what do you mean you do infant mental health? Children don't have mental health. Now we say, yes, they've been telling us since they were born how they feel. Their social emotional is crying, right? Every different cry tells us something about social emotional. So I believe the question renders to the social emotional around school, being a part of environments that increase that. So what we know is that it's important. We've got folks who homeschool, but they still go out and do social activities with others. What we have seen over the last couple of years, we have the other soapbox I'm going to get on for a second is we see third graders right now who've never sat in a chair, right, to be in school because of COVID. They're coming back, they're learning how to sit in chairs and be with peers and share in a lunch line, how to raise a question, how to play on the playground. So absolutely, the importance of coming to school and being a part of social activities to increase social emotional. You know, one of the things we talk about is positive peer interaction, right? So we can also have negative, but sometimes that will work in the favor, right? Sometimes if we want a behavior to change, we put them beside a peer that's got a positive peer behavior. So yes, I think that being in schools and any kind of environment that increases our social emotional awareness, no matter the age. Did that complete the question? Great.
I'm not sure, because I'll see if they get any follow-up in chat.
Okay.
Good to me.
So, unfortunately, many people are losing faith in medicine. I mean, if you take a look at people, how they feel about vaccines, unfortunately, many people don't want vaccines because they don't even trust them. And so now you have teenagers who also aren't believing in medicine because they're hearing and reading things that are not really true. And then they also are defined in them of themselves. And so many of them won't even take the medicine. So you sit there and say, you have this problem and I recognize you have anxiety per se, and they'll say, well, that's great, but I don't want medicine. How do you work with these teenagers and convince them to at least get started so then you can help them with other therapies?
Excellent question as well. First thing that we probably want to do is validate again. Yes, you're right that there's not a lot of data. There are all of these side effects, but so do all the other medications for all the other things, including the supplements or natural things that they're taking as well. Just because it's natural doesn't mean that it's safe, and just because it's medicine doesn't mean it's bad. We also want to reinforce, and we usually take the approach that, hey, it's all about skills and pills. The medication is only there for temporary relief. Think about it as using crutches because you got injured while you were running. What is a real treatment for that is rest and physical therapy and letting the muscles get strong. But if you're in acute pain, there is no way that you can go to the physical therapist or that you could do the weight bearing and other things. What medication does is act as a crutch so that while you are healing, while you're developing skills, the brain is calm enough to actually receive it and build those skills. The other myth that we usually bust during this conversation is this is not a medication for diabetes. Just because you started taking this medication does not mean that you have to take it lifelong. This is a medication that is often short-term, but because brain is a complex structure, the short term in here could be somewhere between 6 to 9 months. The goal always for us as your prescribing clinicians for medication for this particular reason is to get fired, which means you're going to say after 9 months, 12 months, hey, it was helpful, that's great, now I'm feeling better, I'm going to therapy, I have much better self-esteem, my symptoms are better managed, and I don't think I need any medications, I don't need to come see you again. And so giving them that set expectation of saying, first 8 to 12 weeks, we are going to establish if it's working, not working, how it's going. We're going to be your partner in closely monitoring it. Once we find that it's helpful a little bit, we want to have a stable course of about good solid 6 months. And then we're planning of trying to wean it off. So, and see how you do. And we will wean it off, particularly during the holidays, particularly during the summer breaks and low stress times, because we don't want to say that if there is worsening of symptoms, it's because you're off of medicine. It's probably because of those stressors. And so if at all that works, it's possible that you may never need the medication again. But if at all you need it in future, we know what works and we won't have to go through any of this again. And so those two things are setting expectation, giving them a clear endpoint about what would be rational, and then reinforcing this kind of an example of physical pain and emotional pain. And this is really a crutch that is short-term, but not really a true treatment, generally helps them to be a little bit more compliant.
Okay, we have time for one last question.
So I had two questions, sorry. So for WIC, you said there are behavioral health, that you listed them as a behavioral health resources. I was just wondering like what services they specifically provide.
Sure.
So that's the one. And then the two is you were discussing like how to know when to take them off the medicine, but is it more based on what the patient's expectations are as far as symptom relief, or is it both, obviously your professional opinion and taking into consideration what their response has been?
Should I take the medication?
Sure, go ahead.
All right, so we'll just take the medication questions real quick. Yes, it's a partnership, it's a collaboration. And as I said earlier, what we want to really use as a yardstick for medication or no medication is the functional impairment. So sure, they may continue to have the symptoms of depression and anxiety, but at this time, the depression and anxiety is not in the driver's seat. Now you're driving the car. Sure, they're there, but they're more in the back seat, and you're the one who's in charge and who's in control. So when they have that feeling, and when they have an expectation that cure or complete or getting better and being ready to get rid of medication does not mean complete absence of symptom, but it really means that you are now able to manage the symptoms well. You're ready to live with it appropriately and cope with it appropriately. And so that's a discussion that you continually have. And as we said, it takes a village. Probably it involves teachers, parents, therapists, and everybody to come to that conclusion. And the rating scales often help because they may feel that I don't think I'm ready, but you can show them the rating scale and say, look, there has been an improvement of 5 points over the last 6 months. We think you can do it, and let's try and do it as well. Does that answer that?
Really quickly, I want to speak to when the other gentleman had asked questions regarding medications and getting folks due to mistrust. I think that's where we partner again as a village, because you may be prescribing that medication, right? And then saddling up with that behavioral health agency or entity in the school or in the nurse's office or in the behavioral health agency to have the counselors and the case managers talking about those things, right? So reinforcing the importance of medication and also using some natural things like getting outside and walking, exercising, figuring out what works for the person. So I want to just make sure that we partner as much as possible. I can be called the queen of collaboration because I think that it does take every single person in a community. Maybe I don't have a resource, but you do. I am going to get to know you. So as far as WIC, WIC in Athens County, I can speak to Vinton, Washington, and Hocking. They have support, peer-to-peer supports for moms with babes. They've got breastfeeding, nutrition counseling. They provide the food vouchers. Now they're food cards. Is everybody familiar with the food cards for WIC? Is everybody aware that they can get formula, diapers? Not all counties have diapers, so I want to put that out there. Not all are blessed enough to have that, but that you can get formula. For those who are not using formula, they can receive breast pads, instructions and help on breastfeeding. Finish your question? And it is income based, and if you guys didn't know that, but the income is pretty high, the guidelines are. So I always encourage people to apply. And that normally when someone delivers, there's a WIC packet right in that discharge from the hospital along with Help Me Grow.